Well, welcome to our Race to Erase MS forum. I'm Claudia Curry-Hill, your moderator for today's panel. We'll be speaking today about the latest news on multiple sclerosis. Some of you have sent in questions and they will be answered after the presentation of topics. So when I was diagnosed with MS in the early 1980s, the disease took years to diagnose and there were no therapies proven to slow its course. Things have changed. So thanks to the doctors and researchers who participate in the Center Without Walls program, which is funded by the Race to Erase MS, and who are sitting on this panel today. I hope you have downloaded the Center Without Walls panel program for the biographies of these amazing panelists. It is my pleasure now to introduce our panel. Dr. Omar Al-Louzi from Cedars-Sinai, Dr. Liliana Amascua from USC, Dr. Jack Antle from McGill University, Dr. Rohit Bakshi, Harvard, Dr. Peter Calabrese from Johns Hopkins, Dr. David Hafler from Yale, Dr. Adam Kaplan, Johns Hopkins adjunct, Dr. Ellen Mowry from Johns Hopkins, and Dr. Rhonda Voskuil from UCLA, Dr. Emmanuel Wabant from UCSF, and Dr. Vijay Yadav from Oregon Health Sciences. The Race to Erase MS Center Without Walls would never have been created without the vision and hard work of founder and president, Nancy Davis. It is now my pleasure to introduce our founder, Nancy Davis, to kick off the panel discussions. Nancy.
Thank you so much, Claudia. Thank you, everybody who's watching this. I'm really excited. We are going on our 30th year for Race to Erase MS. We're going to have our 30th event coming June 2nd. So this is kind of a monumental thing. Any of this would not be possible without every one of the doctors that is sitting near me. I'm so grateful to be in their presence. Everything that they have done is brilliant. There's so much territory that has been covered to help people with MS, the development of many incredible vaccines, not vaccines, whatever you call them, but different medicines. I guess it is a vaccine, and different ways of helping people with different treatments and so forth. And when we started, 31 years ago, I was diagnosed with MS and told at the time that I should just go home and go to bed and I would never walk again. I was a young mom with 3 kids at that time, and it was devastating to hear that, life as I knew it was over. I had nothing to look forward to in my life. And I thought I didn't want to hear what they were telling me. So I went and got second opinions and third opinions and fourth opinions. And along the way, everybody did tell me I had MS, but they all had different prognoses. And when I listened to the research at some of the best hospitals in the country, they were doing pretty much identical research and didn't know that everybody else was doing the same thing they were doing. And I thought, my gosh, if we could put this greatest dream team of doctors together from all over the country to work together to always communicate, never duplicate research, we're going to find a cure a lot quicker for MS. So it's pretty darn exciting today that there are 24 drugs on the market for MS. I think that's nothing short of a miracle. If you look every single year, there's more drugs getting FDA approval. Some are similar to things already on the market, but the idea that there's so much happening. It's one of those diseases that is treatable. It's going to be curable. We're working as hard as we can. And again, we're in the race to erase MS. We're in a hurry. We want to get there. We know there's a lot of people that are being helped, and there's a lot of people that are not being helped by things that are out there today. So we have a lot of work, a lot of territory to cover. We're going to do it. We're doing everything I can. And each and every one of the doctors here is a major, 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 major genius, brilliant, hardworking, so kind, so generous with their time and their love towards finding a cure. So I want to thank all of them, and I want to thank all of you. And I'm glad where we are today, and I can't wait till we actually have a cure. Thank you.
Thank you, Nancy. So we're going to start our topics now. And the first topic is vaccines and MS. Dr. Liliana Amascua from USC.
Great. Thank you very much. And thank you, Nancy, for putting this together. It's great to be in person and so happy to see so many of you here today on a happy Sunday. So let me just start off by saying that in general, we think that the vaccines that are available in general are probably safe for MS patients. And I think that's the biggest concern that an MS patient usually has is a vaccination going to worsen my MS? Or does it cause MS, right? I'm going to focus on the issue of you have MS and we're telling you to get a vaccine. And then certainly there's been a lot of discussion since the pandemic, right? And so in general, at this time, we do believe that the COVID vaccine definitely its benefits outweigh the risk. We're certainly beyond the just the initial COVID vaccine, but more of like, when do I get a booster? Is booster okay? At this time, boosters of any type, we consider them to be safe overall. The most important question, however, and this should always be discussed with your doctor, is in respect to, is it safe at this moment for you? Is this the right times? And I say this why? Because there's certain medications, for example, like immunosuppressive therapies or B-cell depleters, where we may say, the vaccination timing should be timed, for example, before your infusion or closer to the time of infusion. And that's certainly something that needs to be discussed with your doctor. But we also are talking about other vaccines and the flu vaccine in general. We also think this is safe for all of our MS patients. There's different ones, of course. There's the live vaccine, which certainly now it's being recommended. And there's a specific one for those that are age 65 and older, where it's, supposed to increase a very high immune reaction. And for that one, again, it's important to discuss with your doctor, but commonly we prefer for you not to get that one and avoid, for example, the mist. And again, it has to do with sort of, what type of vaccination, where are you, what type of medication. A different type of vaccine that's come to discussion is the monkeypox. And the monkeypox, certainly you've heard about this over the summer. Monkeypox is an infection that there's, contact person to person. And there's certain individuals that are high risk. And this is certainly something also that needs to be discussed with your doctor. But there's certain high risk populations, including men having sex with men. And so this is an important vaccination for also MS patients to consider. There's different ones. There's two versions. One of it includes one that is given for those that are immunocompromised, and that is another type of vaccine. There's been a lot of also looked at observational studies and looking at, for example, at vaccines that are related to travel. And that's also a conversation that you need to have with your doctor if you're traveling, for example, to endemic areas where there's a need for live vaccines. And in general, the live vaccine is something, again, that we usually want to have a full discussion with you to assess that risk of potentially worsening your symptoms or relapses. And those, types of vaccinations that come to mind include dengue, yellow fever, cholera type of vaccine. And I mentioned this because I just had a patient recently, she's going to South America. And so these are common vaccines that are given by, the travel doctor. And so certainly also having that discussion with your MS doctor is important. So we know what vaccines you might be getting. But again, in general, I think the main focus here is these COVID vaccines and boosters. In general, they're safe. And again, always discuss this with your doctor.
Thank you, Dr. Amascua. So next is COVID-19 update, preventative and curative treatments. Dr. Vijay Yadav.
Thanks, Claudia. First of all, I would like to begin with thanking Nancy for her vision, so that we are 30 years now into this, forum here. And her vision has actually made all of us come together from all around the country to really work for MS together. So I thank you, Nancy, for that. It has made a big difference. I think last 20, 25 years, I've seen the biggest change in MS management. MS treatments are so widely available now, and like effective therapies are available that we can literally shut the disease down now. So short of cure, I think we are almost there. So I think Nancy's vision definitely has played a huge role. So thank you for that, Nancy. So coming back to the topic of COVID, and all of us have lived COVID now for 2.5 years plus, and we have learned a lot. Initially, of course, everybody was very scared of COVID when, we had such a rough time in the beginning. But thankfully, due to the advances in vaccine against COVID, as well as the treatment against COVID, we are feeling much more safer. In terms of MS, MS is itself by itself is not an immune compromised state. So that's one question that many people ask, just because I have MS, will I have bad outcome with COVID? Not necessarily. And we have learned that in a very systematic manner by learning from all the registries around the world, rather. When registries were made of all these patients who were suffering with COVID and had MS, we learned that people with MS were behaving very similarly to the general population in terms of their complication risk or their, the chance of them doing poorly. So people who have who are who have higher age, who are more disabled, unfortunately, they are at higher risk. People who are not as healthy. So MS patients who are not healthy, for example, if they have heart disease, lung disease, obesity, those people will be at higher risk of having complications. So I think since the vaccinations came, that has made a huge difference in how people can feel safe about that. Vaccinations do work. And then, unfortunately, the efficacy of the vaccines, it does go down as the time goes by. So I think that's where the boosters have come up. So I would say follow CDC's guideline. Pretty much everybody should be following CDC's guideline on vaccination. The two class of drugs, like disease-modifying therapy, for which MS patients should be careful about, are CD20 therapies, meaning like the drugs like Ocrevus, rituximab, which is used off-label, and Kesimpta or ofatumumab. Those are drugs where vaccine may not be able to generate as much immune response. So they should be much more careful in terms of being exposed to the COVID virus, or if they get COVID, which I think quite a few people have gotten COVID. So the good thing is there are very effective treatments available now. So the key is to watch the symptoms very carefully, work with your local doctors, neurologists included, let them know, and then let them guide you what needs to be done. Because even if you are on CD20 therapies, most people will recommend that you should start the disease modifying, and you should start the treatment like Paxlovid, which is one of the oral medications for COVID, right away. If depends upon when the diagnosis was made of COVID, then there are guidelines that we have to follow about treatment, whether or not you'll be eligible for oral or you will be getting IV. Whether you're very sick, then you need to be hospitalized. Then there's different treatments. So all of that is done under the guidance of a doctor. But the good thing is these treatments are available and highly effective. So I think it's not as scary time, thankfully, like now versus like when it first came on. So I would say, I think masking, especially for high-risk people, not only the CD20 therapy, but also there's a class of drug called S1P agonist, or examples include fingolimod or Gilenya, Mayzent or siponimod, ozanimod, and ponesimod. All of these drugs can also sort of put people at higher risk of getting complications due to COVID. So they should also be more careful and be vaccinated and start treatment for COVID if they get COVID. Thank you.
Thank you, Dr. Yadav. Next is Existing Drugs, a guide to DMT families and using them to target forms of MS. Dr. Omar Al-Luzi, Cedars-Sinai.
Thank you, Claudia. It's a great pleasure to be with you all today. And I want to especially thank Nancy and Erase MS for organizing this event. I think it's really thanks to all of the support that we've had for the research that we have such a plethora of different medications that are FDA approved for the treatment of MS. As Nancy mentioned, we have more than 24 FDA approved medications, and really the growth has been exponential over the past 10 years. Now, before we talk about the different families of disease modifying therapies and how they're used to treat forms of MS, it's helpful to take a step backwards and quickly review what are the different forms and types of MS. So the most common type of MS is the relapsing remitting form, which typically is characterized by clinical attacks of inflammation caused by inflammatory lesions within the brain, optic nerves, or spinal cord. We know that some patients are at risk of transitioning to a form that's called secondary progressive. Secondary because it typically is preceded by a relapsing course. Progressive is because in between those relapses, patients may notice gradual accumulation of disability or more symptoms. And then the last form is the primary progressive MS, which typically is characterized by gradual and insidious accumulation of symptoms and disability, where month after month, year after year, things get gradually worse in the absence of these discrete relapses. Now, how do we look at those different families of these modifying therapies in the context of those forms? So we have about 3 big families of medications depending on how we administer them. So there are the injectables, the oral medications, and then the infusion medications. The injectable medications were the first to be FDA approved for the treatment of MS, dating back to the mid-1990s to the late 1990s. The 2 big families at that time were the interferons and glatiramer acetate. Those are considered to be relatively safe medications, so there is not a lot of risks of serious adverse reactions that occur from these medications. But at the same time, that's at the expense of their efficacy. So one of the things that we look for is how effective are they at suppressing relapses or new lesions on the MRI. And on the spectrum of low, medium, and high efficacy, those medications tend to be on the lower end of the spectrum, with the exception of one recent injection that Dr. Yadav just mentioned, which is ofatumumab, that was recently FDA approved back in 2020. This medication works through a different mechanism. So instead of modulating the immune system, it suppresses certain types of immune cells called B cells or depletes them. And it's a monthly injection. So there's less infusion or injection fatigue compared to every other day or more frequent types of injections that were seen earlier. Now, the second type of disease-modifying therapies are the oral medications, and there are different families of oral medications that can be used to treat MS. If you look at nationally, the most commonly prescribed are typically the fumarates. So there's dimethyl fumarate or brand name Tecfidera. There are 2 other forms which have the same active ingredient called Vumerity is the brand name for it, or diroximel fumarate, and monomethyl fumarate. Those are thought to alter the function of the lymphocytes, although the exact mechanism of their action is still not known. But what we know is essentially they're on the medium spectrum of efficacy in terms of helping suppress new relapses or new lesions forming on the MRI. They do have certain side effects and do need lab monitoring. One of the things that we look for is, your complete blood counts, lymphocyte counts, and liver function tests. And there's a small risk of PML, or progressive multifocal leukoencephalopathy, a rare brain infection that can be quite serious in patients who develop a low lymphocyte count on those medications. Other types of treatments include the S1P modulators, which include, as Dr. Yadav mentioned, 4 currently FDA-approved medications, including fingolimod, ponesimod, siponimod, as well as ozanimod. Now, those medications trap lymphocytes within peripheral lymph nodes, and as a result, they reduce the number of circulating lymphocytes, and especially the lymphocytes that are autoreactive and might result in MS lesions or relapses. One of those medications, siponimod, has actually been shown to help slow down the rate of progression in active secondary progressive MS, which is excellent because we need more therapies that can hopefully help us slow down the progression of progressive MS, but we need to do better in terms of preventing further progression of symptoms or reversing some of the damage that's already occurred. Now, other oral medications that have recently been introduced as well, including a medication that doesn't necessarily need to be continuously taken, called cladribine, typically administered in the forms of cycles. So patients typically get 2 cycles per year for a duration of 2 years, after which they don't necessarily need to continue on this medication. And it's been shown to be effective at reducing the rate of relapses and disease progression in patients with relapsing forms of MS. And then the last family of medications that we typically think about in terms of the different forms of MS is the infusion medications. And those are divided into B cell depleters, so medications that target lymphocytes called B cells, including ocrelizumab, and its sister medication rituximab, which is a combination of a mouse and human, often used off-label in the treatment of MS. Now, ocrelizumab is not only effective in treating relapsing forms of MS, but it's actually the only FDA-approved medications for the treatment of primary progressive MS, the last form that we talked about. And in one of the big trials of this medication, it was shown that this medication can help reduce the rate of progression by about 24% compared to placebo. So certainly not a cure for MS, but at least a first step in terms of targeting progressive MS and hopefully trying to halt disease progression. The other type of infusion medication is natalizumab or Tysabri, which is a medication that blocks the entry of lymphocytes into the brain and the spinal cord. And by doing that, it really prevents those inflammatory lesions and MS relapses from occurring. And at the same time, one of its major side effects is what we call PML, or what I just mentioned as the rare brain infection, because in preventing the lymphocytes from entering the brain and trying to fight infections, if there's any prior exposure to this virus, it can reactivate and cause this serious infection. And the last medication I want to mention is alemtuzumab, or the other brand name for it is Lemtrada, which you can think of it as a way of pulling the reset switch on the immune system. This is a medication that targets both B and T lymphocytes, and it essentially tries to reset the immune system, where after depletion, a period of a 2-year course of taking this medication, or 2 infusions 1 year apart, what happens is that the immune system reconstitutes. And in that reconstitution, we see that the risk of new lesions, new relapses from the MS goes down. But along with that, there is a risk of autoimmunity from the reconstituted immune cells and those lymphocytes. The 2 most common organs that can be involved with this autoimmunity are the thyroid and the circulating platelets. So it can increase the risk of bleeding. So this is kind of a quick whirlwind tour of all the different forms of treatments that we have. It's really exciting that we have so many options for our patients. Typically, it's something that we try to personalize to the best extent possible. And with that, I'd like to thank you all and happy to take questions at the end.
Thank you, Dr. Al-Lusi. And next we have MS treatment plan, conventional or aggressive treatment. Dr. Ellen Mowry, Johns Hopkins.
Hi, everybody. And I want to echo everyone's thanks to you, Nancy, for hosting this amazing event. It is great to be here. And when I think about erasing MS, I want to echo what some of my colleagues have said. Having worked with people with MS for quite some time, I can say confidently I have more and more people coming into my clinic saying, you know, doc, I feel most days I forget that I have MS. And that is exactly where we want to be. Understanding that not everybody has derived the benefit of the changes that have occurred in the field. We nonetheless do want to keep up hope that the changes are occurring. And it always takes longer than we hope, but they're coming. So having worked with people with MS since the mid-1990s, if you were around the field at that time, you might remember when the first medications came out and they were available only on lottery. And typically the people who were the most sick with their MS got the medications first. And now, as you heard, we have more than 20 medications approved for multiple sclerosis, which is a really enviable position to be in. It creates a new dilemma because when a person is newly diagnosed with MS, they say, which one should I go on? And a lot of people in this country are still just given a list or a brochure or a set of brochures, and the doctor tells them, take it home and let me know what you want, which is not a really great evidence-based way of selecting a treatment. You heard from Dr. Al-Lusi that we divide the medications based on how much efficacy they have. And efficacy is defined as how well they work to prevent relapses and new white spots or MS spots on the MRI scan, as defined in clinical trials. Not how well they're working in the real world, but if you were a person who was eligible for a clinical trial, how well did it work in that setting? But we know that the people who are enrolled in the trials aren't the same as the broader population of people living with MS. And furthermore, that in the trials, the duration of treatment is often pretty short. And so we don't really know long-term what the impact of the treatment, different treatments are. Really, the question in my mind when I help think about this with a given person is the choice that we make today going to impact where you are 5, 10, 15 years from now, how you're functioning at that time? And I would argue that we don't really have a full set of data for that right now. We know that when we follow groups of people living with MS, there are studies to say, well, people who got started on the strongest medicines, within the first several years compared to many years later, were more likely to still have less disability accrual over time. But it doesn't really tell you a lot about those people. Like, why did they get changed early compared to somebody who got on a stronger medicine later? If you look at clinical trials that try to capture how well these different medications impact on long-term disability, the trials are really not comparing strategies. Like, one group gets, like, by a flip of a coin, assigned to a stronger medication, and the other group gets a more modest medication, and they're off to the races. And if the person on the modest medication is doing well, great. They stay on that medication. And if they're not doing well, they stay on that medication in the trial. It's not a treatment strategy trial. It's randomizing people by a flip of a coin to two medicines and hold. And that's not how we practice in the real world. So a person who decides to start on a more modest medication in the real world, we say, great, if that's what you're going to start, we're going to track things really carefully. And if it's not working, we're going to change the medication. And so really, we don't have trials to date that have done that have looked at the treatment strategy, that have been very intentional about defining, okay, that's too much activity on that medicine, change. And so we have two trials that are ongoing now across the United States and some sites in Europe that are doing that. One is Treat MS, which I am running with my colleague, Dr. Scott Newsom. And the other is Deliver MS, that's being run out of Cleveland Clinic and in the UK. And we're taking people who are newly diagnosed with MS and are willing to participate in the study and flipping a coin and saying, you're either going to start a strong medication out of the gate or a more modest medication, regardless of what you're on. Just like in the real world, we're going to follow you like a hawk. And if anything happens when the medicine should have kicked in, that's a conversation for you and your doctor to switch the medication. And we're looking to see over time, is that first strategy really important? Can you not, try out the more modest medication? And if it's not working, switch? Or does that first, 6, 12, 18 months really make a huge difference in terms of where people are doing long-term? So in Treat MS, we've enrolled, I think, 750 people so far. And the trial should read out in late 2025. So we're really excited and hope that it really helps newly diagnosed individuals with MS with that first decision to have a very informed decision about what treatments they're taking. Thanks.
Thank you, Dr. Mowry. Next is how to define treatment failure and manage high efficacy drugs long-term. Dr. Emmanuel Wava, UCSF.
Thank you, Claudia, and thank you, Nancy, for having us. Maybe I pushed the wrong button. So I think that, spending your Sunday with us is really nice. And I think it's a good way for you to get a better handle on questions you may have that sometimes are not answered in a clinic visit because there's so many things that are discussed in a clinic visit. I think this opportunity is really a great opportunity to have more of a discussion. So the topic I'm going to discuss a little bit is actually a topic I had the chance to present at an international meeting 2 weeks ago. And I felt it was an important topic to consider. One is, how do we discuss someone who has what is called treatment failure or breakthrough disease? What's our definition of that and what do we do? And the other thing is also, how do we manage patients who have been on high efficacy drugs who are doing super well over time? Do we stay the course or do we change things? So the first thing to discuss is, how do we discuss treatment failure with patients? If you put 100 neurologists in a room, you probably would have about 10 definitions of treatment failure or breakthrough disease. So it doesn't mean that the treatment necessarily is not biologically active. It means that clinically or on the MRI, we can see either changes with relapses or new lesions on the MRI or changes in disability. So some people have discussed very strict definitions of treatment failure, saying if there's any single lesion on the MRI, if there's any single enhancing lesion on the MRI, any relapse, any progression of disability, then this is treatment failure. We should switch treatment. It turns out that we probably should think more carefully about the definition based on which treatment patients are on, because we know that if we're already using a very high efficacy treatment, our options to switch to higher gears are going to be limited. And so some people have come up with definitions of minimal disease activity. And there's been a fair amount of work showing that if there was just one new lesion on the MRI over the course of a year or two, it's actually not necessarily something that will predict an impact years down the line in terms of staying on that treatment. So many of us use the MRI as a very sensitive way to detect activity under the radar screen. I think everyone would agree that if a patient is compliant with treatment, take the treatment regularly, if they have a relapse, we should switch. I think not too many people would argue about that. But where do you set the bar on the MRI is a little different, probably different also depending on the age of the patient and so on. So now what do we do with patients who are on high efficacy drugs and have been completely stable? So by that, I'll say they've been on treatment for, let's say, 5 years on a medication such as Tysabri or an anti-CD20 agent, so rituximab, ocrelizumab, ofatumumab, not yet because it's not been on the market for so long. Some other treatments also that are not first-line treatment like cladribine or alemtuzumab are treatment to also consider highly effective, but we are limited in how long we can use them and how early we can use them. So patients who have had no relapse on these medications have had an MRI completely stable, and they are, willing to continue treatment and they tolerate treatment well. I usually discuss staying on the treatment, but sometimes de-escalating a little bit in terms of the dose or the frequency of the treatment. So most of these treatments are infusions, so IV drips, given either every month or every 6 months. And there's really more and more data now showing that if you have been stable for several years on this treatment, you can probably increase the time between infusions. But this is also something to discuss with your doctor, because depending on some markers of the disease, we have to tailor treatment. So I would be very careful if someone has had a super active and severe disease before being on these treatments, because it means that if we decrease treatment frequency or dose, they may be more likely to have, again, some disease activity breakthrough. There's also sometimes options on the long term to actually switch to an oral treatment, because sometimes people are tired of doing IV drip treatments. That has come up with the pandemic. You heard my colleagues earlier discuss with COVID infection and also with COVID vaccines. There's been the discussion of some medications that are highly effective, dampening the efficacy of vaccination or increasing the risk of severe infection with COVID. So in that setting, some patients prefer actually switch to a treatment that's highly effective, but is not associated with that risk. So we really have to balance a lot of things in the decision-making, look at the age of the patients, look at how many scars are on the MRI when we start treatment and how many relapses they've had. So very important to discuss that with your doctor.
Thank you, Dr. Ravant. And now we're going to talk about MS research updates. First, Epstein-Barr virus and biomarkers with Dr. David Hafler from Yale.
Thank you, Claudia, for organizing, and Nancy, again, thank you for all that you've done. So an interesting question to all of us is, what causes multiple sclerosis? And the working hypothesis for a long time has been something happens in the environment which triggers autoreactive T cells against myelin to go into the brain and cause the disease. And we, in fact, have identified autoreactive T cells in the blood of MS patients that are activated and inflamed and are likely causing the disease. But the question is, what triggers them? Now, EBV, there's been a lot of smoke around Epstein-Barr virus for a long time. Almost 100% of patients with multiple sclerosis have been infected with EBV, but it's about 93% of non-MS patients. So again, smoke, but nothing definitive. In what I think is a landmark paper published by my dear friend and colleague, Alberto Esquero, at the Harvard Chan School of Public Health, did a very interesting experiment. It was published in the journal Science about 3-4 months ago. He looked at recruits, in about 1 million recruits into the military, and asked how many of them have MS and how many have been infected with EBV. And turns out that about 1,000 were diagnosed with multiple sclerosis in that time period. Now, when you join the military, they draw blood from you every year. So you have blood samples on all these recruits who converted to MS. And what he found was that the risk of MS was increased 32-fold after infection with Epstein-Barr virus. But what was more remarkable, there's another biomarker called neurofibrillary light chains, NfLs. Now, these are, it's like a CPK of a heart attack. That is, these light chains are released into the blood or spinal fluid when there's damage, okay? And it could be any damage. It could be stroke, it could be Parkinson's disease, but which damage the nervous system, the NfLs go up in the serum. So we asked the question, did EBV conversion, that is going from EBV positive negative, was that associated with increases in these NfLs in the MS patients? And the answer is, in 49 out of 50 cases, it was. So that's direct evidence that prior infection with EBV was associated with MS. But here's the problem. We and everyone, including my grandmother, well, not my grandmother, we've all been looking for evidence of EBV, of the biology. We've looked in the brain of MS patients, can't find EBV. We've looked in the blood of patients with MS, can't find it. So if it's there triggering the disease, then we ought to be able to find some signal, unless it's a hit and run. It may trigger the disease and not have any biologic activity. So we're about to embark upon a really neat experiment. We're going to come to you for funding for the next round. Okay.
I can't wait.
Yeah. So we maybe been looking in all the wrong places. Where does EBV live? In the nasal pharynx. It doesn't live in the blood and doesn't get into the brain. So we've gotten approval at Yale, IRB approval, to do tonsil biopsies in new onset patients. So we're going to see
having a COVID test.
no more than a COVID
Only
test.
the bad person that does it.
Well, that's the bad COVID test we call brain biopsy.
Yeah.
So what we have ENT, the head of ENT is going to come in and do a needle biopsy of new onset patients. And we have all these wonderful techniques, look for EBV. So we're going to start that hopefully in the next few weeks to see if we can find the smoking gun. Now, I'll ask you all to think about this for a second. What is the experiment we can do to definitively prove, or provide, I don't like the word prove, convincing evidence that EBV causes MS? It's a simple experiment we can do, which we're trying to get someone to do. Think about it. What's the experiment? Vaccinate. If we can vaccinate to EBV, another vaccine, but we can vaccinate and prevent MS, then that will show causality. There's a disease called subacute sclerosing panencephalitis. The neurologists here know the disease, caused by a defective measles particle. Wasn't that rare when I was a resident? That was before, a long time ago. And then we did an experiment. We vaccinated everyone to measles. The disease disappeared. We don't see it anymore, at least in the United States. So an interesting experiment will be to take individuals at high risk for developing MS, first degree relatives, and vaccinate probably tens of thousands of individuals and see if it prevents disease. So that's another interesting experiment to do. I'll just end with other biomarkers, getting back to treatments. I mean, if I may just give my own opinion, there's, I think, one treatment for MS that may be on the market. Every trial to date has shown that the earlier you treat with more effective treatment, the better the outcome. That's been very, very clear. I would not confuse the word aggressive with efficacy, because the two may be separate. And we at Yale basically started everyone with B-cell depletion, one of the B-cell depleting drugs. And because they're clearly the most efficacious, to me, they're not necessarily the most aggressive in terms of side effects. But the problem is what we don't know, and this gets back to the trial Ellen is working on. If you treat early, do you prevent the onset of secondary progressive disease? And that we don't know. We know we can stop the flare-ups, the exacerbations, but what we don't know is by early treatment. I think you do. I've been seeing MS patients since I was a freshman in college with Dale McFarland in 1970s. That's 50 years. And we don't see, we seem to be doing better, but that's going to be the critical experiment. And we are doing looking for biomarkers to determine how long you have to be on treatment. Can we find biomarkers in the spinal fluid blood that tell us that the drug can be stopped or need to be restarted? And these are things we're working on. So I'll stop there.
Thank you so much, Dr. Hafler. And next, new therapies, BTK inhibitors, Dr. Peter Calabrese, Johns Hopkins.
Hello, good afternoon from Baltimore, Maryland. Can everyone hear me okay? Great. So first of all, very, very sorry I can't join you. I hear the weather's much nicer there than it is here. It was 45 degrees and 15-mile-per-hour wind today. So hope you're all enjoying LA. Thanks, as always, to Nancy for everything you do. You're absolutely amazing year in and year out, just keeping this going. And you've made such a difference. It's really, truly incredible, and we're very appreciative.
Thank you.
So I'm going to tell you just very briefly about a new class of pills that is likely to be coming out very soon called BTK inhibitors. That stands for Bruton's tyrosine kinase, which is an enzyme that's in a lot of cells, but it's notably in the B cells that you've been hearing about. And this is coming along at a very opportune time because you all know about the successes of B cell depletion with the anti-CD20 monoclonal antibody therapies. Those basically kill the B cells entirely. So drugs like Ocrevus and Kesimpta work really, really well, as you've heard. But they kill the B cells. And if you might imagine, if you're 22 and diagnosed with MS, living a life with no B cells might be a problem. And indeed, we already have data that after years and years of B cell depletion, some people start getting more infections. And so we need a long-term strategy. And these drugs, the BTK inhibitors, may target the B cells without killing them. And so that there might be just a little bit milder and could be a good long-term maintenance strategy. There are now many of these. 4 of them are in phase 3 clinical trials, which means they've gotten through phase 1 safety, phase 2 proof of concept, and they are starting to look promising. They, as I mentioned, will suppress the activation of the B cells without killing them. So that's good. We think it might be a way of preventing the B cells from activating and causing the damage that we know that they can cause in MS. And very interestingly, this particular enzyme, the BTK, is also expressed in other cells. And it's possible that the B cell inhibitor effect goes beyond that to some of the peripheral blood immune cells and even into the brain. So that's important because we know in later stages of MS that the inflammation gets what we call compartmentalized, or the cells get stuck in the brain. And many of the drugs that we have right now are working predominantly by targeting the circulating cells in the bloodstream. And so some of the companies have developed BTK inhibitors that are what we call CNS penetrant. That means that not only do they get into the bloodstream, but they've been devised in a way that they will cross the blood-brain barrier and actually target that same enzyme in the brain cells. And one of the types of brain cells that has been found to be affected by these drugs are the microglia. And you may have heard that there are microglia and astroglia, and normally they're there to provide what we call homeostatic or protective supportive functions to the brain cells. But in chronic inflammation, such as in chronic progressive MS, these glial cells become aberrantly activated and cause damage, and we need to develop a way of turning them off. And there's hope that the BTK inhibitors that get into the brain, the CNS penetrant ones, may actually suppress that. So a lot of excitement around this. They're going to be likely several different types of drugs with subtle differences between them. I think that overall that I can see them as perhaps a first-line drug right out of the gate for people with milder MS. I think that Dr. Hafler is right that for people with very active MS, that the anti-CD20 monoclonal antibody therapy is probably a good first way to go. But I can imagine after 4 years when someone's quiet that we might switch people over to these. But of course, we need to see the results of the phase 3 trial and make sure that the safety part of the equation also looks good. So far, there are some reported side effects related to the liver, as with many drugs, but we'll have to see the exact details before we make any specific recommendations. But overall, good news for the MS field, brand new class of medications that targets the cells that we know to be important in MS. So very exciting to see what happens in the next year. Thank you.
Thank you, Dr. Calabrese. And next, restoration, repair, and rehabilitation, Dr. Jack Antel from McGill University.
Thank you very much. I had the pleasure to serve on the medical advisory board or the scientific advisory board of the foundation a number of years ago. And those of us who watched this interactive group were so impressed how interactions and collaborations, both within the foundation and also even the wider community, really have contributed to the advances you've heard about earlier today. But the advances have also shown us what problems remain. And that's where I think many of the new challenges, and David Hafler has mentioned to you the issue of will progressive MS continue to be seen? Peter Calabrese has mentioned the possibility of going into the brain compartment. And these are the issues that we have to think about. As all of the others have spoken, all of the treatments that are available now were developed because of their effects on the immune system. In other words, the immune system living outside of the brain, trying to change their properties or ablate some of these cells and see what effect they had. And as mentioned, the relapses have been successfully dealt with. What is the effect on the progressive phase of the disease? And although some of the drugs have been approved for progressive disease, they have been approved in a subgroup of people where there still is this systemic inflammatory activity. And so we have to do better in terms of how are we going to go after this progressive phase of the disease. And now are we going to have to, as Peter mentioned, the compartmentalized activity, what's going on in the central nervous system. So I'm afraid we're going to have to introduce you to a new vocabulary. You're all experts on B cells and T cells and monocytes. You heard the word microglia. Now we're going to bring you to the world of the oligodendrocyte and the myelin. You already heard about astrocytes. The cells that make these oligodendrocytes are the cells that make the myelin that's damaged, and that who makes these cells originally? These are progenitor cells or stem cells. Why are we interested in it? Because the technology and ability to understand these cells is just moving ahead very rapidly. What did we learn from the early phases of MS? With my colleague Tanya Kuhlman, Tanya, what she did is she looked at the brain of people with MS from the beginning through the whole phase, and the cells that make the myelin, the oligodendrocytes, although the myelin is damaged, there is very little, there's not a major loss of these cells. In other words, they've withstood the initial injury, but if we look over time, they're lost. And so these cells are progressively being lost, but maybe there's a window in which we can intervene and we can protect these cells and perhaps make them function better. And also, if you look in the brain, you see these cells that are called stem cells. They haven't quite committed to being the mature cells of the brain, and can we make them work better? And in fact, now we're matching up to the world of neurobiology because there's a huge literature and a huge amount of study about how these cells, the myelin cells, develop, and can we take advantage. What else have we learned from looking at early MS cases and when you recover from relapses? In fact, repair can occur. And so both from imaging, we'll hear more about imaging in a minute, and from actually looking at the brain, you can see that there is capability of repair. So why doesn't that occur? And that's the challenge. And I think one of the challenges we really face is this is a human disease problem. Our animal models are all acute injury or relatively acute injury. The cells probably have different properties than in humans. And so we're going to face the issue of translating the basic observations into human disease. And we're going to need the biomarkers to know that we've intervened, that the MRI shows us exquisitely the inflammatory lesions, but it's a real challenge still to show that there is recovery. And we're going to hear more about how updated MRIs can be used perhaps to show us when we intervene.
How long will that take?
These studies are already ongoing, and the first clinical trials with using restoration therapies. The other I want to mention, which is just the observations are just appearing, and it's the collaboration of the major genetic network that David has been part of, and led by my colleague who fortunately is going to be joining us at McGill, Adil Harood, working at UCSF, but on his way to Montreal. And the genes that are the genetic susceptibility, the genes that determine susceptibility to MS are not the same genes that determine susceptibility to develop progressive forms of MS. And whether there's something different about the wiring or the makeup of the cells in the brain, and that's what I think is a new frontier that we can look at. If there really are genetic predispositions to progression, can we understand what those genes are doing to cells in the brain? And can we take advantage? So I think that's a new frontier that we're going to hear much more about. I noticed in the topic given to me was, in addition to repair, was the rehabilitation. And I hope we'll hear more about that. That's not particularly the field that I work in, but I'm struck that whether we are going to get much more sophisticated and move to rehabilitation in terms of what takes place in real life in your homes, and that rehabilitation could be ongoing on a 24-hour period with the modern apps that we have and monitoring of people in their home situation. Can we improve quality of function by taking advantage of the advances in engineering, electronics, all these electronic applications? I think this is a field that's been overlooked in the MS world. And the last comment I think we have to face in the MS is that, again, when we think about progression of disease, we're not only looking at the immune mechanisms and how the cells, we have to interface that with what occurs over the course of aging. And I think we're going to hear about that as well.
Exciting.
Thank you.
Thank you, Dr. Antal. And next, a topic that I'm interested in is growing older with MS. Dr. Rhonda Boskel, UCLA.
Hi, thank you for having me here. I want to say congratulations. Nancy. It reminds me of, yeah, this one's not working too good. The light's not working. Okay, how about this? Is this working? Okay, great. So Nancy, 30 years, it reminds me of the story of the stream and the rock, where the MS is tough, it's hard and it's difficult, but the water eventually wins. So after the years of persistence and persistence and persistence, the water eventually wins. And so congratulations on your persistence for 30 years. So I want to talk today a little bit about progressive MS and aging, because so many drugs that we have, they're for relapsing or MS. They do a great job of it, but progressive MS we really have very little for that's highly effective. So the background on this is that, as you know, with MS, patients go from relapsing or remitting, which is a very inflammatory phase with relapses, lots of enhancing lesions on MRI, to the secondary progressive phase, where really there's not that many enhancing lesions. They're not having relapses, but they're getting worse disability progression. They're getting brain atrophy. Now, this was always known to occur, and it happens after about 15 years of having the disease. And they always said, well, it's due to the disease duration. So after so many years, you're going to go from RR to SPMS. That was the idea. But actually, when people started to look closer, it really wasn't so much the disease duration. It was age. So MS patients get MS around 20 to 30, and that's around 40 to 45 to 55, they go to the progressive phase. So if you look closer, it's really not so much the disease duration of having the disease, it's age. So what is happening with age? It could tell us the key to progressive MS. Now, again, progressive MS and with aging, it's not like when people are 45 to 55, they're suddenly getting new relapses. It's not like they're getting new enhancing lesions. What they're actually getting is they're getting worse disability accumulation in the absence of relapses, and they're getting worse brain atrophy. So this is what we're talking about. The question is why? Well, is there anything we can learn from health? Is there anything and aging? Is there anything we can learn from other neurodegenerative diseases and aging? I think there is. So during health, we know that aging is associated with brain atrophy in healthy people, brain atrophy. It's also associated with cognitive decline. IQ tests are actually, prorated. I mean, this is the way it is. Aging affects cognition and it affects brain atrophy. Why? And could this also be happening in MS, and not just for cognition, but other disabilities, right? The other thing we know about aging is the biggest risk factor for getting other neurodegenerative diseases, such as Alzheimer's disease, Parkinson's disease. Aging is the biggest risk factor there is. And these, by the way, are not autoimmune. They're not related. They're not due to the classic T lymphocytes and B lymphocytes that are responding to myelin antigens. Alzheimer's and Parkinson's are intrinsic diseases within the central nervous system or the brain. And so aging is the biggest risk factor for those diseases. So the question is, what could aging be doing to the MS brain to make it go progressive? And I think this is a key, it's a key clinical observation that we can make sense of, and we have all the tools to figure this out at the genetic level, the molecular level, the imaging level, to figure out what's going on with the brain during aging in MS. And I think the implications will be twofold. One will be, do these treatments that have been designed for younger people with relapse-remitting disease, do they necessarily work as well in people with progressive MS? And I think there's already evidence they don't work as well. The one we have now, the anti-B cell therapies, look like it works best in people that are younger. They have relapses and so forth, not so much the older people who are not having relapses. So we need to understand how those treatments work or don't work in older people by doing more trials in older people with MS. They may behave differently. It may change the risk-benefit ratio of when to use them or not. The other thing is, if we can understand the effect of aging in MS and other neurodegenerative diseases, we can actually come up with new treatments that are targeting cells in the brain, which you've heard about. Microglia become activated with aging. Astrocytes change with aging. Synaptic connections, they change. And also oligodendrocytes that Dr. Antel mentioned, it's known that remyelination occurs less in older as compared to younger individuals. We have to understand what aging does to the brain and the cells in the brain to harness a new drug to treat progressive MS.
Thank you so much, Dr. Voskuhl. And next, imaging the brain and spinal cord, novel ways to diagnose and monitor MS. Dr. Rohit Bakshi, Harvard.
Thank you so much. I'm going to talk about two aspects of how MRI is used in MS. First is, how do you diagnose MS? And then once you have MS, how does MRI help us to monitor MS? And I'll talk about some new discoveries that have gone on in the past few years as we talk about this. So first of all, getting an MRI scan is very important to see if a person has MS or not. And what we're going to look for on the scans, whether it's brain or spinal cord, we're going to look for a specific shape of lesions. They're also called bright spots. We're going to look for the location of those lesions, and we'll see how many lesions there are. And this can help us differentiate MS from other conditions that can cause spots in the brain, like diabetes or strokes, things like that. So to make this more definitive, there's been advances in the past few years to make the diagnosis more accurate. And one of these discoveries is called the central vein sign. And what I mean here is that many MS lesions, especially those that are in the white matter of the brain, they have a blood vessel in the center of the lesion. And it's a vessel that has flowing blood throughout. And until very recently, we couldn't see that blood vessel in the center of the lesion. There's now new MRI techniques available, and many centers are using these. It involves having a good scanner and having the right method available to you. And this allows us to actually see the blood vessels in many of those lesions in the center. And that gives us more power to diagnose MS accurately. And of course, you want to diagnose it correctly because you want to get on the right treatment as soon as possible. And if you don't have MS, you need to get that taken care of, whatever it might be. Let me now talk about monitoring using MRI. Once you have MS and you've been diagnosed, you're likely going to be put on therapy. And what we'd like to know is the therapy working? Are you getting worse or are you stable? And MRI is one of the major tools we have to show us that. Just like if you have high blood pressure, you check with a cuff, you check your blood pressure. If you have diabetes, there's a blood test to see how your sugar is doing. MRI is very similar to that for MS. It shows us the disease for the most part. Typically, what we've done in the past is we look at the MRI scans year by year, sometimes every 2 years in some cases. We compare them side by side to see if there are new lesions that were not present on the previous scan. That's a simple way to determine if the disease is marching on or whether the disease is stable. It turns out, unfortunately, that is not sufficient for us to understand all of the worsening of the disease that may be occurring in our patients. What we now understand is that, in particular, in the later stages of MS, the progressive forms Dr. Voskuhl just described to you, we call that secondary progressive MS or primary progressive MS. In those stages especially, while we don't see typically a lot of new lesions in our patients, what we might see is that the old lesions are actually growing slowly. So they're getting bigger over time. We call these chronic active lesions. We can also call this slowly expanding lesions. Now, those are somewhat challenging to identify simply by looking at scans side by side in the clinic or in front of you. You really need mathematical techniques to process the scans and analyze them piece by piece. You need to have what we call a software pipeline to be able to do this properly. So there's a lot of research going on right now to figure out how common is it for patients to have slowly expanding lesions? How do we measure it? And what's the implication for predicting how the patient is going to do? Quite strikingly, so far, what we've seen from this research is that up to 2/3 of patients with secondary progressive MS have slowly expanding lesions. So just think about it, how common that is. And it's something we really didn't even know how to measure several years ago. Dr. Calabrese very nicely tied into this that one of the important concepts that may relate to the slowly expanding lesions is the presence of microglial cells at the edge of these lesions. So we're very hopeful that possibly these new treatments that are being tested may also limit slowly expanding lesions. So I think I'll stop with that. Thank you all very much.
Thank you, Dr. Bakshi. So last but not least, managing depression and fatigue with Dr. Adam Kaplan, Johns Hopkins adjunct.
Thank you very much, Claudia. I do want to also echo the thanks for Nancy, Claudia, and Liz for putting this together and giving us a chance to be with you guys. And you've almost made it through. You just have to get through me and everything is good. So, when I was thinking about this talk, I came across this cute little one-liner. It said, I was going to tell you a time traveling joke, but you guys didn't like it. So, the idea is that I could go into the future and then come back and know. And I thought to myself, what would I like to see in the future about depression? So I am going to talk about depression and not make you depressed, I promise. So, and I went backwards initially, and I thought of the Declaration of Independence, because we're still trying to fix some of the things that were left out there. But it said, we hold these truths self-evident, that all men are created equal and they are endowed by their creator with certain unalienable rights. Among them are life, liberty, and the pursuit of happiness. Of course, what they meant at the time, all white men are created equal. And really what we are now doing is trying to evolve and in our thinking and our understandings that we need to add things like all women and men, all people of every race and ethnicity, and all people regardless of their disability or type of illness. With one illness in particular, one class receiving a great deal of stigma, perhaps the most, which is mental illness, and depression is what I'm talking about today. So money is one way of quantitating the equality. So just to give you an idea, I did some quick calculations earlier this morning. Just look them up. I didn't actually calculate these. Actually, one I did. But so women earn 82 cents for every dollar a man earns once you adjust for numbers. Blacks earn 70 cents for every dollar a white person earns. Mental illness, in terms of treatment, 44 cents are spent on treatment for mental illness for every physical health illness that's covered. And in terms of NIH funding for depression research, depression has 11 cents spent on research by the NIH for every dollar spent on MS research. It's not that I want to cut back on research for MS at all, but it just gives you an idea. So why care about depression in MS? Well, turns out depression is the number one correlate of quality of life for people with MS, and the number one correlate of quality of life for the caregivers and the family members, because it's hard to be up a creek and find yourself having to adjust to life with MS. It's especially hard if you lose your paddle and now have somebody who's dealing with multiple chronic illnesses. Turns out that the number 3 cause of death across the lifespan is suicide, which is the lethal outcome in the worst cases of depression. And 30% of people with MS will have thoughts of suicide at some point during the course of their lives with the illness, and 10% will attempt suicide. And again, this is the worst outcome of a lethal disease like depression. And that MS and depression are locked in a destructive spiral. So I urge you to think about the fact that MS causes depression. We now have evidence that depression causes MS. It's one of the risk factors, like vitamin D and these other risk factors, Epstein-Barr that we've heard about today. Also, worsening of either one makes the other worse, and treating either one successfully improves the other. So it's, treatment of depression is also, as it turns out, the antidepressants that we're using turn out to have anti-inflammatory effects. And one of the things I hope to be able to talk about next year is we now have a mechanism through which the antidepressants are working to actually have their anti-inflammatory effects. So the good news is that additional funding is starting to go for mental health, in large part because of the COVID-19 outcome. And so it is worth knowing that it's not just when COVID is done, if that, whatever you call done, but there's the recovery, right? What we've all been through, this traumatic experience once in 100 years. And so I just call people's attention, if I did depress you, the fact that now there's 988 is your suicide prevention lifeline. It's the way of quickly getting help. So my hope is that if I could look into the future, there would no longer be discrimination in the areas that we've talked about today. And this is what people would mean when they recite the Declaration of Independence. We hold these truths self-evident, that all people, regardless of at least gender, race, and disability, are created equal. After all, since the writers of the Declaration of Independence put happiness on the short list of unalienable rights, then maybe we should reconsider whether depression, the opposite of happiness, should ever have been overlooked or discriminated against in the first place. Thanks very much.
Bravo. I'm always wowed by you, doctors. You just amaze me. Thank you so much. And now to the fun part of our program is the lightning round to answer collected questions. And so Dr. Waband, I'm going to need your assistance with this.
Yes, Claudia, I'm ready. Are you ready? So some of you may have already written questions, so you can pass them around and we'll add them to some of the questions we have received before starting the meeting. The goal is to have a short answer for short questions. And I'll start with the first question we have, and I'll ask Dr. Alouzzi to answer that. Do I require MS treatment if I rarely relapse?
Yeah, that's a great question. So we recognize that MS can actually be quite heterogeneous in its presentation, and that different patients can exhibit different levels of activity. And by that, I mean inflammatory activity, not only in difference between the patients, but also in difference amongst the age span. So today we've heard a lot about the effect of age and the years since symptom onset in terms of also dictating not only what risk of inflammation there is, but progression as well. So at the moment, most of the evidence points that a lot of the treatments that we have that are effective at preventing inflammation do work, and they work even, the greatest benefit that we get are in people who are very high risk of relapses. The answer to the question depends on how frequently are you having relapses, but also because MRI is such a sensitive tool for us to look at lesions and detect them, what has your MRI shown as well during the course of follow-up? And we don't know the exact number of years of stability that we need, but most clinicians would agree that at some point, if you've been stable for a number of years and your MRIs haven't shown you lesions, then it's worthwhile to consider going off therapy gradually or trying to taper some of the treatments depending on what you've been on before.
Thank you. So question 2, I'm going to ask Dr. Mowry and Dr. Antel actually to answer that question. Do you think that there's a strong and consistent diet along with regular intensive exercise can stop the deterioration of myelin?
Ellen, go ahead.
So I do a lot of work in the space of lifestyle interventions, and I think probably everybody here spends time with the people with MS they work with talking about the impact of healthy lifestyle. We don't have randomized control trial data to suggest that those lifestyle interventions could impact on remyelination or on neurodegeneration in people with MS specifically, but there are growing and emerging data to suggest that things like, getting adequate sleep and exercising regularly and, keeping your body otherwise healthy and free of cardiometabolic disease is probably relevant to long-term brain health. And whether those things therefore impact on MS-specific outcomes, for example, remyelination or preserved neurons in areas that were damaged by MS, or whether they impact on age-related changes in the brain and therefore combine with MS damage to, affect long-term outcomes, we don't know. But in my mind, we do know that those interventions can be helpful for overall body health, preventing other diseases. And so we spend a lot of time doing that. We have done some work on fasting style diets. I led a small pilot trial, showed some interesting biological results, but we don't have clinical data to support an impact on myelin specifically or neurodegeneration per se.
So if you said, would a healthy lifestyle take away MS? The answer is no. As Ellen just mentioned, if you look at some of the scientific experimental studies, fasting diets actually will promote remyelination in an animal model. Now, I think it's also, important to emphasize when we think of repair, if you focus just remyelination, we could say, what does starvation do or what does a specific drug do? But this whole healthy lifestyle probably has many other effects on the overall brain in terms of plasticity, reorganization of brain. And I think if you're measuring in terms of functional outcome, quality of life and how you carry out your activities, I think that's a very important aspect.
So
I'm sorry?
said fasting diets. Does that mean intermittent fasting?
So what's been done is they've put animals on fasting diets, and they can, after they induce a mild injury, and they can show that there's actually more repair in that setting. Okay, now how do you translate that? And whether Ellen can comment more, whether that was the intent of, trying to, Ellen, maybe you want to comment how you translated it.
There are lots of different terminologies. We tend to use an overarching theme called fasting style diets or fasting mimicker diets, where there are extreme versions such as you don't eat every other day for 24 hours, to milder versions, which are considered things like time restricted feeding, where say you eat all of your meals within an 8-hour period out of 24. And then there are variations in between. The study we did, for example, people did intermittent calorie restriction, where they 5 days a week ate a normal amount of calories, but 2 days a week ate only 25% of their daily calorie needs. So there are different versions that have been tried both in the animal models of MS and in people with MS and other conditions. What I would say from what we've learned in our own studies is that intermittent calorie restriction is pretty hard to sustain for a long period of time. Like, we shipped people food for 8 weeks and they did okay with a few cheats, but after I sit with people, so I lived the experience, but most people weren't able to make it, say, a full year after that, kind of trying it on their own, even with education, whereas some of the time restricted feeding is a little bit easier. So
I will say persistent fasting without any breaks will get rid of your MS and get rid of you. So that's
accurate. Accurate.
It's one way to look at it.
I would just say, in terms of diet, we know that high salt and high fat induces inflammation. There's increased salt in tissue in MS patients. We should all be on a low salt, low fat diet.
Okay, so just reminding the panel, we are trained to take as many questions as we can, so short answers to the questions.
Really, lightning round.
So that's for Dr. Kaplan. What are the most evidence-based approaches to support MS through mind-body work? I'm asking about things like meditation, stress reduction, cold plunges, etc. Evidence-based alternative therapies and interventions.
Oh, no problem. Really quick. Whenever you thank people, you're always at risk of forgetting someone. And Manuela, please accept my apology for forgetting. Not only is she hurting us today, but as Nancy has made possible, we will all exchange ideas together tomorrow. And that is also what Emmanuel. So thank you, Emmanuel, as well. The mind brain is what this is all about. It's that your depression will worsen your MS, that it turns out that in the studies that were done, for instance, of comparing talk therapy, which had, also things like exercise and mindfulness and these kinds of things, compared to Zoloft, turned out that that they were equivalent in mild depression, not severe depression, but mild depression. The problem was you had to screen 10 people to find one depressed person who was willing to exercise. So sometimes it's, easier to reach for the easy things, but there is no question that we are beginning to understand better this mind-brain connection, and that all of these things, mindfulness and yoga and stuff, do have evidence to suggest that they improve MS, as well as some improvement in depression.
Thank you. Next question, what's coming? So for Dr. Yadav, what's coming out for primary progressive MS? There are over 24 treatments for relapsing remitting. Any feedback about a trial about AK-188 and targeting EBV?
So I think I would say for primary progressive, the challenge has been even Ocrevus is not as effective as it was sort of, shown in the clinical trial, because most of the people who actually in reality have primary progressive, they're older patients. The clinical trial was focused more on the younger patients, so less than 55 years of age. So I don't think that we really have very effective treatment for primary progressive right now, including Ocrevus. I think even though it's approved. And then the challenge for the newer therapies, which are EBV based therapies, they will be I mean, they are good in concept, but I'm not sure in reality how practical they will be to really show the differences. So I think that and there's no easy answer, but yeah, treatment, the good thing is we are having a lot of options that we are testing out right now, but it's a long ways in my opinion.
Thank you. So next question for Dr. Calabrese. What do you think about NervGen NVG-291? Would it lead to epilepsy?
So thank you for this question. This is a really interesting compound that in the laboratory has been shown to promote remyelination and nerve injury repair. Basically, the concept is that in any number of neurologic diseases, whether it's a stroke, trauma, Alzheimer's, or MS, that the brain injury causes scar tissue to form. And that scar tissue may limit the extent of the injury, but it also limits the reparative processes. And so this drug targets the interaction between the scar tissue and the myelin-making cells and the nerve cells, and it blocks a receptor that is important for that, what we call inhibitory signaling. So now the myelin repair cells can actually do their thing and make myelin, and nerves can sprout again. At least this is what it looks like in the animal model. So there's a lot of excitement about this compound, and it's moving through the long process of being tested. And we hope it actually shows a positive signal, because it would be something very different and may address a critical need that has not been addressed with remyelinating or putative remyelinating compounds to date, which just kind of push the myelin-making cells to differentiate and make myelin, but it doesn't address the inhibitory factors that are present in MS plaques. And so I think it's a very clever strategy, and I really hope it works moving forward.
Thank you. So the next question for Dr. Hafler. When do you think there will be an MS cure?
In a very short
So
answer.
in 1970, when I started, that was a question people asked. Maybe we already have. Maybe B-cell depletion early on cures the disease, but it's a complex genetic disease, and we're not going to be able to change the genes. There are hundreds of genetic variants that are associated with it. The word cure is an interesting word, and maybe I could discuss it better after more 2 carbon fragments. A drink, a glass of wine. Yeah. I'll
Thank
keep
you.
it brief. Yep.
I'll take the next question. How long can you take Tysabri without causing long-lasting side effects? So as far as we know, the main concern with long-term use of Tysabri is slow brain infection, we call PML. We can detect it now in patients in terms of whether they are at risk of having this infection with a blood test for JC virus antibodies. We do every 6 to 12 months. So if you are negative for JC virus antibodies, we have patients who have been on Tysabri since it's been on the market. So, 14 years basically, or 15 years. So that's safe. Next question, Dr. Amezcua. Is it safe to take Tysabri while pregnant? How dangerous is it for me to stop my medication while pregnant? Are there other medications that are better to take while pregnant?
Well, I try to be short, but I think the most important thing is there is data with Tysabri that's stopping, before, because commonly what we do is we try to stop the medication before one is trying to conceive, depending on what medication they're on. The shortest answer, we prefer other types of medications for you to be on, including B-cell depleters. Those are much easier to manipulate if somebody's contemplating family planning. With Tysabri, we have to be careful because in many cases, the patient, the female, she may relapse. There's a rebound component may happen during that first trimester or second trimester. And so there is studies that suggest that it's safe enough to even keep it till the second trimester and then pull back. So it's a complicated question. It's a question that requires to talk about these possible benefits and risk with a doctor. But certainly, the best thing to do is that if you're family planning is to start that conversation earlier so we can better make choices of the treatments that you might be.
Thank you. Next question for Dr. Aluzzi. What can I do after 3 rounds of Lemtrada? It lasts about 3 years for me. What's next? I'm 60-year-old, too old for bone marrow transplant and not interested in experimenting.
That's a great question. I think in the large part, it will depend on first, how you're doing in terms of symptoms, how your follow-up in terms of your exams has changed since finishing Lemtrada. And another factor to consider is how stable have your MRIs been. If things have been stable, you haven't noticed any worsening of your symptoms, then really what we would do is monitor and make sure that you're not at risk of any new lesions or relapses. The other thing to consider is if there's been signs of recurrent activity, which can happen very rarely, even in the post-Lemtrada era, then it's really worth a discussion with your neurologist as to whether trying another type of immunotherapy might be warranted. Of course, this will depend on a lot of factors, not only age, but also how active have things been, not only clinically in terms of relapses, but also in terms of new lesions or enhancing lesions on the MRI. So I think that the answer depends on how active things have been. Typically, if there's been stability since the last round of Lemtrada, then typically no further treatment, but we'd like to monitor things and make sure you're not at risk of developing breakthrough disease.
Thank you. Question for Dr. Calabrese. Where do you see medical exploration transitioning within secondary progressive? I want to know if there are pathways to slowing it down so I can improve my quality of life.
Sorry, I put myself on mute. So fantastic question. This is something that we're all thinking about, and there's a lot of research. So I mentioned the compartmentalized inflammation, getting drugs across the blood-brain barrier. That's going to be critical. Second, you heard about the glial cells. The microglia are really important. There's also another glial cell called the astrocyte that Dr. Voskuil and our lab is studying intensively that seems to be very important. And we've identified targets on the astrocyte that might be amenable to intervention. The astrocyte secretes factors that inhibits myelin repair and causes direct damage to nerve cells. It was shown in a Nature paper in 2017 that certain types of astrocytes can actually kill the neurons. And so we have to stop them in that process. And then in addition, I think there's been less emphasis on understanding the biology of what are called the axons, the nerve wires that relay the impulses. We all know that myelin is really important, but ultimately the myelin is important because it keeps the axons conducting, and we have to keep the axons alive and healthy to receive the myelin. And so there's a lot of interest and study going on right now on how to keep the axons functioning. And there are actually drugs that are in early phase testing for that. So I would say that we've gotten a lot smarter in the last 10 or 15 years in understanding the biology underlying progressive MS. And now we're starting to see companies and trials targeting these various different factors within the brain that we know to be the underlying substrate involved in progressive MS. So hang in there. I'm very optimistic that we're going to get there, just like we had to wait a long time to get the immunotherapies for relapsing MS. I think the stage has been set for progressive MS, and we're going to start to see drugs get approved for it.
Thank you. Question for you, Dr. Calabrese again. What do BTK do in healthy people? Short answer. Please.
Well, we don't know. As I mentioned, they may have some toxicities with the liver and GI side effects. They don't kill or deplete the B cells, as I mentioned, but you need your B cells for function, so they're probably a little bit immune suppressive. So I wouldn't recommend taking it just in a preventive fashion.
Thank you. Dr. Hafler, stem cell therapies.
So stem cell therapy is a misnomer. It's bone marrow transplant. We're not putting stem cells back in to regrow things. It's high dose cyclophosphamide, which clearly works. It's a very effective treatment, but there are major side effects associated with it. We haven't used it up at Yale. I think we used it up in Boston. I think it works, but B cell depletion, other therapies works well. And just aside, B cell depletion doesn't deplete B cells. You eliminate circulating B cells in the blood, but there's still B cells in the lymph nodes. So they're not all depleted. Just as an aside.
What percentage of the B cells are depleted when you take one of those medications?
Well, with anti-CD20, basically goes down to zero in the peripheral blood, but they're still present in the lymph node. They go down by about 60-70% in the spinal fluid, and they change rather dramatically. We are going to start doing a study, doing lymph node biopsies in patients after B cell depletion to look more precisely what's happening in the lymph node, but they're still there. They're not gone.
I'll take the next question, which is about glutathione. So can you address the latest research in the therapeutic potential of glutathione, also called GSH? I have actually funding from the Department of Defense to exactly lead a study in progressive MS addressing this question. So the study is ongoing at UC San Diego and UCSF. If I'm able to find more funding, I may be able to open another site in the US, but still trying. Next question.
Emmanuel, he has a question.
Oh, yeah.
I'll just follow up because I was asked about in progressive MS about smoldering lesions, and it fits with what Peter Calabrese said of what, as we understand what's going on in and around the damage area in progressive MS, that we have the tools experimentally to manipulate these cells, the astrocytes and the microglia, and see what products are good and what products are bad. The real challenge is going to be the translation. We've been very fortunate in relapsing MS, where the imaging could predict within several months that you had an effect or not. And that's why with what Rob Bakshi said to you, in seeing these smoldering lesions by MRI, and developing additional biomarkers, we need to have a rapid way of saying, yes, we've had an impact and can predict what's happening. If we have to wait 3, 4, 5 years to evaluate each of our therapies based on using thousands of patients, the trajectory is going to be much longer than what we hope for. So I think the translation and use of biomarkers is an extremely important issue.
Next question. What is the most interesting new approach of treatment you can think about that was not mentioned today? Who wants to take that question?
We mentioned everything.
I think we've been fairly exhaustive. So that's our short answer is we don't have any other. Next question. Anybody knows about the results of the study that involved stopping taking disease-modifying therapies for elder people who with no relapse over 5 to 10 years? So who here was participating to that trial? Okay, so Dr. Yadav.
So this the study that we're talking about. The study that we're talking about was called DISCO MS trial, or discontinuation of the disease-modifying therapy in patients who were stable MS. These were people who were 55 years or older and had to have stable disease, either relapsing or progressive, for more than 5 years, including stability on the MRI. So the results of that study was, so the study was set up as a what we call non-inferiority study. So the two arms of the study, meaning the people who stopped the disease-modifying therapy and who continue the disease-modifying therapy, they were not inferior to each other. However, the group or the subjects who were in the discontinuation arm, they did have slightly higher risk of MRI activity as well as relapse. So which was considered sort of not significant in terms of the big picture of the trial, but it appears that there are certain people who may actually have disease activity despite having stable disease for many years if they stop disease-modifying therapy. So I think people should be careful and discuss with their neurologist about the implications of the trial.
Thank you. Dr. Bakshi, why radiologists after MRI just say no changes and they don't say if lesions have expanded, decreased, or changed to black holes?
Well, there's really 2 points you're making. The first is that when an official read is done by an expert, they're very often looking at 30, 40 images a day, and they're really flying through them to get through it, because you can't spend hours and hours on each case. I would say first, it's really important to have the neurologist or the provider who takes care of your MS encourage them to look at the images and do these direct comparisons as well. Spend time with these images, and you'll often look for things that maybe are not in the official report. And then the second point is that, unfortunately, it is difficult to see slowly expanding lesions, even with an expert looking at films. You really need to do fancy computer techniques that are not readily available. They're done in the research setting, fortunately. And really, if you had an expanding lesion for, say, 5 years, if you go back 5 years, you might get to see that retrospectively, but even that would be difficult.
Thank you. Next question is for Dr. Hafler. When infected T cell passes through the blood-brain barrier, will damage be permanent on the blood-brain barrier and other agents can also pass through?
So the blood-brain barrier keeps out proteins from going from your blood into the brain. So it would seem logical that if proteins can't get through, then T cells wouldn't be able to get through. But in fact, T cells go right through the blood-brain barrier through certain mechanisms. And that's what we think starts. When that happens, there's inflammation and the blood-brain barrier breaks down. And that's what gadolinium enhancement's about, the leakage of the GAD. It heals itself. The blood-brain barrier heals itself. But when the T cells go in, as we've heard before, it generates scars in the central nervous system. So the blood-brain barrier becomes intact after the inflammation.
Thank you. Dr. Kaplan, any studies done regarding neurofeedback?
I think I'm gonna have to ask. Can I get a help? Phone some friends on this one?
You can. Anyone wants to comment on that? So it's a general question, right? I mean, neurofeedback is used for lots of different symptoms.
Yeah. So I mean, if you're talking, so certainly there's a fairly extensive literature on biofeedback for its role in anxiety as well as pain. So there certainly are, studies that I know of there. I don't know if someone else.
There is an FDA cleared biofeedback technique available now, just coming online. We have one center in the Boston area, which focuses on bladder symptoms, where patients can be trained and try to control their bladder better. This does not involve any medications. It's not invasive in any way. It just involves controlling how your brain works. So we'll see how that pans out in the future.
Dr. Voskuil, if you never had a relapse, but disability progression has increased, is it best to have a higher efficacy disease-modifying treatment?
So if you never had a relapse and you're having increasing disability, so it's primary progressive MS.
Probably.
And the question is, what is the whether to be aggressive or not? I mean, I don't know that I would start out with the most aggressive treatment, in the sense that the aggressive, again, you can argue about whether we should define things as aggressive or efficacious, but generally the efficacious is related to reducing relapses, and they're targeting, for example, Ocrevus is one of the best, and it targets B cells. So if you've got somebody who's never had any relapses, I don't think it's a great idea to be super aggressive. If you look at the Ocrevus trial, for example, it was most effective in people that were younger. They were still having enhancing lesions, and they were still having relapses to some degree. It's not black and white. It's a continuum of having a transition. And in that study, again, when you broke it down, Ocrevus was approved, and I think it's a great drug, especially for people that are, again, younger, having enhancing lesions and having relapses. But for somebody who's having none of those, I would really want to weigh more closely the risk-benefit ratio before doing that.
Next question, if you are on a B-cell depleting treatment, is it or will it be beneficial to look into the new oral pills BTK inhibitor for help? Maybe Dr. Calabrese, since you discussed that, or Dr. Hafler, if you want to.
Maybe again, we don't know if the BTK inhibitors work. Let me just make a comment about a progressive MS and Ocrevus. So it showed a bit of a signal. I totally agree with Rhonda just said. It wasn't very impressive. The question is, getting back to the blood-brain barrier, Ocrevus does not cross the blood-brain barrier. There are B cells behind the blood-brain barrier. Did it not work for that reason? And that's one thing interesting about the BTK inhibitors, because they do cross the blood-brain barrier. Something that hasn't been discussed, the question what we haven't discussed, CAR T cells against B cells. They will cross the blood-brain barrier. I think someone ought to do a clinical trial with CAR T cells in progressive MS. So this used to treat lymphoma. So they're T cells, which is anti-CD20 basically, or CD19 on a T cell. So it gets the monoclonal antibody across the blood-brain barrier, and it will kill B cells. We know works in CNS lymphoma. So that's something we haven't talked about, and I think it'd be worth trying. I know we've explored doing a clinical trial, but that would be some way of potentially crossing the blood-brain barrier. One other point that we're learning is that progressive MS, Alzheimer's, macular degeneration all have the same signature of inflammation, the astrocyte microglia. We're learning that these are all common processes, whether it be T cells, drusen in the eye, amyloid plaques in the brain. They lead to common forms of neurodegeneration. So this is a bigger problem than just MS in terms of dealing with neurodegeneration. And it's not for lack of trying. But neurodegenerative diseases are tough. We know how to suppress the immune system. We don't know how to prevent neurodegeneration that effectively yet.
Dr. Calabrese, do you want to add anything to the discussion?
Well, no, I think Dr. Heffler made some really good points, and I would just emphasize that we really need to see the clinical trial data to better understand the efficacy and safety, so that we can make educated decisions. So we're not going to get too far ahead of ourselves with this class of drugs, but it's exciting and potentially interesting, but we just have to see what the data show us. And I again emphasize that some of these new MRI techniques that Dr. Bakshi was telling us about really could help define whether the drugs are impacting on the slowly evolving degenerative lesions with the iron rim that we think potentially could be amenable to drugs that get into the brain, but we'll have to see.
Yeah, and especially because a couple of months ago, right, one of the trial with BTK inhibitors has been put on hold by the FDA because of concern of liver toxicity. So some patients could not continue to enroll in that trial, but the ones who had at least 60 days of treatment could stay in the trial to continue monitor safety. So we have to, look at results when they are available regarding safety and efficacy. So the last question I have, I'm going to ask Dr. Mowry to answer the question. I'm a 66-year-old woman who was diagnosed with MS in 1994. I have been on many medications over the years. I walked until 2012, and presently I use a Hoyer lift and an electric wheelchair. I go to PT and use electric stimulation of my muscles. Is there any new medication that may help increase my strength and ability to move?
That's a really great question. One of the most interesting talks I heard at our international conference for MS research was really focused on precision rehabilitation. And you heard Dr. Antel suggest that we're kind of understudying rehab in people with multiple sclerosis. So in this really cool talk, the scientist was describing how they use 3D videos combined with specific muscle measurements while people are walking to figure out, is the problem with this person's walking related to muscle specific weakness or the muscle being held too tightly, or both? And by doing that in combination, they could figure out which muscles needed to be targeted for strengthening and which ones needed to be calmed down with Botox. And therefore, for a specific person, improve their capacity to function. And honestly, I thought that was probably one of the best talks I heard. The medications that we have to try to improve things like spasticity and whatnot, they work to some extent, but they have a lot of side effects. And the way Botox, I think, at least in my clinical experience, is used right now is kind of generic. They're like, oh, I'll just give whatever 50 units to everybody in this muscle, right? So I really love the idea of customizing the therapeutic approach to the person based on what their MS is doing to their specific muscle groups.
Thank you very much. So that was the last question. So Claudia, I'm passing the microphone back to you.
Okay, thank you, Dr. Wahba, and thank you, doctors. It's has always been so enlightening and so educational, and thank you very much. But in conclusion, I would like to turn it over to Nancy Davis.
Thank you, everybody, for today. It's so fascinating to listen to these sessions. There's so much that's happening, and I know tomorrow you're all gonna be together in a room and just collaborating on so many new ideas and new things, which is amazing. We wouldn't be where we are today with MS research if not for each and every one of you and the contributions you've made. And I love sitting through these sessions and hearing everything that's happening. It's really very exciting. So thank you, everybody. And here we are at almost 30 years with Race to Race MS, and we need to cross that finish line and find a cure for MS. So thank you.